So, good morning, everyone. I must congratulate organizers for number one organizing this conference and this particular symposium. And I was impressed by the theme that integrating this mental health into primary care. This itself was good enough, but adding SDGs to it, this is a wonderful concept. Because our speakers will deliberate on it. If you look at each and every SDG, not only health, everything is related ultimately to the mental health. So this is a wonderfully thought topic, that SDGs and mental health, and what can be done. And we expect that uh, here you will have a piece on the major contents, that what is the global burden, global experiences, what are WHO's experiences, what is the status in the country, and actually what are the challenges of converting policy into action and implementation. We will share our experiences, and so that the main message is given to the audience like you, who are experts in your field, that what can you do actually to carry forward this agenda, so that at the grassroots level people are benefited in terms of better mental health services. So over to Dr. Yutaro.
Thank you. Thank you
So
very much.
you have the introductory slide of Dr. Yutaro. Yeah, this is Dr. Ganguli.
Dr. Yutaro.
That's okay. Good morning, everybody. This is Dr. Yutaro Setoya. Yeah.
Yeah. So he's technical officer and officer in charge of WHO country, liaison officer in the Kingdom of Tonga,
Yeah.
and doctorate in health sciences by University of Tokyo, Graduate School of Medicine, and community mental health. In the free time, he told that he has spent his life. Life is still there, but till now, in mental health, and major achievements and contributions, that before moving to Tonga, he served as technical officer mental health at the WHO division, Pacific technical support in Fiji, supporting the Pacific countries to strengthen their systems for 3 years. And I tell you that working with the health system is a big challenge. So he has worked for 3 years to strengthen their mental health systems. This is great. And then at WHO headquarters, and he has worked on substance abuse also. And prior to joining WHO, he was engaged in training, education, research, and at National Research Institute, universities, and NGOs in Japan. This is great, and we are really honored to have him over here to share his experience.
Thank you. Thank you for the kind introduction. Yes, I'm Dr. Yutaro Setoya. Just call me Yuta. I'm really honored to be here today to be the part of this session and as a chair. As Professor introduced, this is until 4 months ago. And 4 months ago, I have joined the WHO India office as a team leader for NCDs and comorbidities, including mental health. But as you can see, my passion is in mental health. So I'm really happy. I've been working on NCD for the past 4 months, but I'm happy to be back here in the mental health arena, and I really feel comfortable because my background is mental health. In fact, my mental health or global mental health journey actually started from India. I was a researcher at the National Institute of Mental Health. It's similar to NIMHANS. Japan has NIMH, Japan. And I was a researcher there, looking after Japanese issues like reducing psychiatric beds, increasing community mental health service, etc. But I always wanted to work at the global level. And I was looking at the literature and found this very good NGO called Sangat, which all of you know, of course. And I wrote to Vikram, actually. I wrote an email to Vikram. Can I go to see your service? I'm a researcher in Japan, but interested in global mental health. And he actually replied back and I was able to go to Goa to see the service. It was back in 2002 or something. So I took my holiday, not as a mission. I took my holiday, personal holiday, to visit Sangat and meet Vikram and learn about the good experience. And that really motivated me to work in global mental health. And after that, I went to Melbourne University as a visiting scholar under Professor Harry Minnis, and also, with Professor Helen Harman and everybody. And then I had an opportunity to work at WHO headquarters at the Department of Substance Abuse. So I'm really happy to be back in India to work on mental health. I mean, India has a lot already, a lot of research, there's a policy, but as Professor Aggarwal said, what does it mean at the community level? How to scale up and implement? So I'm looking forward to this session. The session starts with my presentation, which I talk about the global arena, and then Dr. Ganguli will talk about the WHO's work in India level, and Professor Aggarwal will finish with the talk about how to put policy into practice. So thank you very much.
So, yeah.
Okay. So I'll talk about the role of WHO in fostering public mental health related activities, also through my experience, 13 years experience in WHO. Next slide, please. Can I do it myself? Okay. Okay. One of the great things WHO did is that they put mental health into our constitution when the WHO was established. They made a definition of health. And at that time, I think it was still a new concept, but they put as this: health is a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. It is a great thing is mental health is already mentioned back in 1946, because WHO's role is to promote health. And it clearly shows that mental health is the part of health. So and of course, good mental health is the foundation of well-being. It is essentially a positive thing. Mental health is a positive thing, which usually we think as a negative thing, as a disorder, disease. But in essence, meaning of the mental health is a good thing, and we need to promote good mental health and well-being because it's the indispensable part of health and foundation of good health. I'd like to talk a little bit about the global burden of mental health. Many of you already know, but we have just launched a new report on mental health in 2022, and this is data from that report, WHO report on mental health. So almost 1 billion people, or 30% of all people globally, had mental disorder in 2019. So 30% of all people had mental health issues. In addition, 283 million had alcohol use disorders, 36 million has drug use, 55 million had dementia, 50 million had epilepsy. And sadly, 703,000 people had lost their life to suicide in 2019. So it is just seeing the prevalence, it is a huge problem. And as you know, there's a calculation called DALIs, which add up all the disease burden. And mental health account for 5.1% of global burden. It's based on different calculation, we have different figures, but at least by 5.1% of the global burden for health is from mental health issues. And unlike NCDs, which affect older age, mental health usually affects from the youth, from the birth, from the children, from the adolescent to the young age. Many people suffer mental health from their young age. And also because of stress and distress, the poverty affects their mental health, and they have higher prevalence than other population. Because people with mental disorders are neglected or discriminated, their physical health is often neglected, and combined with suicide issue, people with severe mental health conditions die 10 to 20 years earlier than the general population. And in addition, the COVID-19 pandemic increased stress and distress for all global, everybody on the earth. Everybody, each of us has different COVID-19 story. Everybody, all of us is affected, from the children to old age, we're all affected, and that increased the stress, overall stress of the world, and increased the prevalence of anxiety, depression, but all other mental disorders. So the burden of mental health is extremely high. The other work WHO is doing is to collect mental health data from all the countries every 3 years through the Mental Health Atlas project. And it shows that the change is very slow. We do it every 3 years, 2014, 2017, 2020. The expenditure for, especially for low and middle income countries, the expenditure for mental health per capita is less than $1 per capita. And if you see the most right-hand side of the table, it's about the percentage of mental health expenditure out of the health expenditure. So the burden was at least 5%, but in low and middle income countries, they spent only 1% to 1.6% of their total budget to mental health. And even for high income countries, they spend only 3.8% of their health budget. So that leads to, of course, lack of workforce. And when you see low income countries, there's almost none. There's only one mental health workers per 100,000 population. So almost nothing. Of course, it increased as they go up the ladder with the higher income groups, but still in lower middle income countries, upper middle income countries, there's a very few people work for mental health area. And of course, that limits the number of community resources. So the same story for the health service, almost non-existent in low and lower income countries. In addition to that, there's a human rights violation issues in many countries, including where I came from, Japan. Human rights of people with mental disorder are violated. So WHO is trying to address this issue through awareness raising. We do a lot of review, mental health review, law review and regulations to follow the international standards, CRPD for the disability, people with disability, Convention for the People with Disability. And we also have a toolkit and various training under the WHO Quality Rights Program to review mental health facilities and provide recommendations. Basically, we try to, essentially what we do is to compare the quality of mental health care with the quality of the general health care. If you see, go to the unit, so for the inpatient unit, if the level of the beds, the food, the quality of service is about the same level, because the quality differs among countries. But if it's a difference within the same country, the quality of the bed provided for general health care and quality of bed and food provided to mental unit is different, that's the issue. We need to address that. At least it'll be par with the general healthcare level. So the session is about mental health and SDGs, and WHO did lobbied a lot when back in 2015, the SDG targets and goals was made together with all the different organizations and NGOs. We lobbied a lot, and we made the final cut for the mental health to be included in SDGs. It looks very small maybe, but to put this mental health into SDG was a lot of work, and very, very proud that it was included. It's included, mental health is included under SDG 3.4 by 2030 to reduce by 1/3 premature mortality from non-communicable diseases through prevention and treatment and promote mental health and well-being. And for that, there's two indicators. One is about mortality rate for NCDs, And the second one is to reduce suicide mortality rate. The second one is included in SDG 3.5 about prevention and treatment of substance abuse. We have two indicators, one about coverage of treatment intervention for substance use disorders, and the second one is the consumption per capita of the alcohol. But beyond the health SDG target 3, mental health is related to many other SDG targets. It's shaped a broad range of factors across different domains, social determinant of health, we can say. Promoting mental health and well-being, call for intervention that address the broader environment. So we promote mental health, and when people have better mental health, a lot of different SDGs could be improved. And on the other hand, if the SDGs for these different area is improved, the people's mental health will improve. So it's important to intervene into different area, especially for social determinants of health. For example, if we take the second one, if we promote gender equality, that will promote women's autonomy, and it will improve women's health. For the third one, for SDGs 1, 2, and 8, 9, 10, for example, we increase food security if people and improve poverty. Of course, their stress will be decreased, which will improve our mental health. Of course, on the other hand, for example, if we improve the people's mental health, they will be able to work again, and that will contribute to other SDGs as well. So, etc., etc. So, what I'm trying to say is, mental health is correlated to almost all of the SDGs. So, promoting mental health is a very important part of the Sustainable Development Goals. WHO has been making a policy document called Comprehensive Mental Health Action Plan 2013 and 2030. It was initially 2020, but unfortunately the target was not achieved, so we extended to 2030. And at that time, in 2013, I was at WHO headquarters supporting the development of this action plan, and it was encouraging to see that many countries talked about the importance of mental health to achieve this action. In the Seattle region, we also have the mental health action plan for the WHO Seattle, which follows the global document, basically to strengthen leadership and governance, increase community-based services, implement promotion prevention, and strengthen information system and evidence and research. There are targets for each of these objectives, and there's a key areas listed for action for member states. I think Deborah, next session by WHO Mental Health Director Deborah Kester will probably talk about this more in detail, so I will not go into too much detail. Before joining India, I was in WHO Western Pacific region. I was in Fiji office and then in Tonga office for 9 years, 3 years and 6 years, so total 9 years in Western Pacific region. And in Western Pacific, we also developed a regional framework, which we think we are proud actually to went beyond what the WHO HQ has been developed. So we thought to go further for that. And there are 3 themes for that: to refocus the mental health agenda to include well-being and reaching the unreached, transform mental health support and care into a community-based ecosystem of health and social service and innovation, and embed mental health into the setting and journey of daily life communities. I'll try to unpack these next slides. So the first strategy, I think, and I think it's applicable not only in the Western Pacific, but also in other regions and also in India. So we need to refocus the mental health agenda. We tend to focus on disease from the disease perspective, the hospital care and inpatient care and outpatient care at the hospital, but we need to go beyond that and refocus the mental health. We need to refocus the mental health agenda. We learned from COVID that mental health is not only for people with mental disorders. Everybody is affected. So we need to refocus the target, what we try to achieve. So we need to include well-being and reaching the unreached through leadership and champions mental health in all policies and policies and strategies generated from the needs of the community, supported by strategic communication and advocacy. We need to go into the community, listen to their concerns, not only to the concerns of, of course, the concerns of people with disabilities, mental disorders is important, but we need to listen to the general public and we need to address those needs using communication and prevention and advocacy. So we need to refocus our mental health agenda. So we have been doing this in many ways. We can do better. There's an example from World Health Day in 2017. Each year in WHO birthday on 7th April, we have different themes. And 2017 on April, it was depression. And it was one of the very successful campaign. We did a campaign across the globe called Depression Let's Talk. And it actually increased a lot of understanding about depression among the general population. Maybe I supported many Pacific countries to do this. Also, for refocus the policy direction, I have established, supported the Pacific Island Mental Health Network. And the network had biannual or every 2-3 years, they have a what we call a PIMNET meeting, gathering all the Pacific mental health focal points to share knowledge from global and regional level, also from lessons learned from each countries, but also to try to refocus their policy direction towards more broad area, not only to their traditional hospital-based care. And also we listen to the countries and try to respond to the needs of the countries. Sometimes it was emergency mental health, sometimes it was about COVID response. I supported many countries. So this is a map of the Pacific, actually. So there's so many small, this is actually Australia on the bottom. But there's a lot of small countries. There's 14 countries in the Pacific, and I was supporting them from 2014 to 2023. So I reviewed a lot of policies and laws, and some of them, for the first time, they had developed a mental health policy. The second direction, which I think is important, is to transform mental health support and care. I think it's happening in a different level across the globe, but it is important to support them at the community level, including health and social services, using innovations, training the workforce. So we need to share that we call it task shifting or task sharing. So things tasked from specialists to non-specialists to social, community workers to the community. So to provide a full range of intervention at all levels, but especially at the community levels and at the community itself. So for that, WHO has been providing guidance called Mental Health Gap Action Program, MHGAP, which aims to scale up services at the community primary healthcare level. We have the MHGAP Intervention Guide. My role when I joined WHO in 2011 at WHO headquarters was to develop training material for MHGAP. So I made a lot of training material for the videos, case studies, etc., slides, to implement MHGAP across the countries. And this is an intervention guide which provides protocols for clinical decision-making for primary healthcare or general healthcare settings. So as a pilot from WHO headquarters, I introduced MHGAP in various countries across the world, like Ethiopia, Afghanistan, Uganda. And also when I moved to Fiji, I tried to introduce MHGAP and other WHO trainings through capacity building training in many of the small Pacific Island countries. Not only MHGAP, we provided training for psychological first aid because this small island is very prone to disasters, earthquakes, tsunamis. When I was there was a big volcanic eruption in Tonga. and also cyclones, etc. So emergency mental health was a big area we provided support. And also, not only for the general doctors and nurses, we provide training for community health workers to identify, refer, follow up, and raise awareness among the community. The third direction I think important is to embed mental health into the sectors beyond health. So into the settings and journey of daily life. By engaging and empowering communities with tools and platforms that enhance protective factors and reduce risk factors across the life course, and fostering social interventions and partnerships that co-benefit mental health and other social sectors. We need to go beyond health because, as I explained earlier in the slide, health is not only about the health sector. There's a lot of social determinants which could be improved only through other sectors. For example, for effective suicide prevention is that if we provide social security, if the people have enough to live, we can reduce the rate of suicide prevention, suicide. So that's one of the determinants we can change through policy actions. So it's important to embed mental health beyond the health settings. One thing I did and I'm proud of is to introduce health promoting school in Tonga. So it aims to improve school environment and capacity to support healthy lifestyle among the children. I don't know how many of you know Tonga, but it's a very small island country in the Pacific. It has only 1 lakh population, but 100,000 population. But and their number one priority is obesity. They're one of the most obese people in the world. 80% is overweight and 60% is obese. So many people die from NCD. So WHO, together with the Ministry of Health of Tonga, has done a lot. They've done a lot to change people's behavior. But it showed it didn't change, it all failed. So we changed our focus to focus on the children, to the next generation, because changing adults' behavior is almost important. It's not impossible, but almost impossible. So we focus to intervene in the school settings. And there were 3 strategic areas that in physical activities, water and sanitation, and hygiene. And the third component, we included mental health and well-being. So we did a training for the teachers on importance of resilience, well-being of the children, and introduce policies, school health policies, including anti-bullying policy. It started with like 14 pilot schools, but now it's expanded across all schools in India, or at least all the public schools in India and most of the private schools. Of course, the result is yet to be seen because it takes 20 years, maybe 10 years, 20 years to see the results, but hope the future generation of Tonga has a healthier physical, healthier eating behavior, also more resilient mental health. So this is my last slide. So just a repetition, but I think it's important to shift our focus. We need to refocus the mental health agenda to include well-being and try to reach the unreached. We traditionally reach only to those who come to the clinic, but we need to reach to the community, reach to the people who are suffering in the dark. We need to transform mental health support and care into a community-based ecosystem of health and social service and using innovation. I think the Telemanas of India is a very good example of that. And to embed mental health into the settings and journey of daily life in our communities. Thank you very much.
We may have questions at the end. So there will be cumulative time available. Yeah. So thank you. I think now we invite Dr. Atreyi. Can you put this slide of Dr. Atreyi? Yeah. So we are very proud to be for her to be here. She is our alumni. She did MPH from our Department of Community Medicine and School of Public Health, and now she is leading the program at the WHO India office. So she is public health professional and experience of implementation of various national health programs. This I will focus in my talk also, that experience of implementation is something very important. It's very difficult. So, and she had formal training in medicine and public health, and she has worked as clinician and public health specialist in different areas of public health. And she joined WHO India and since 2010, and she is presently the focal point for mental health and substance abuse, healthy aging, and palliative care. All these three issues are very important. She is supporting Government of India to take forward activities on mental health and substance abuse, and we hope she will support the institute also to carry forward the agendas on mental health. And during COVID-19, she, as a member of WHO core team, she supported the national response to COVID-19 pandemic and gave inputs to promote the mental health and psychosocial support. Over to you, Dr.
Thank you. Uh, At the outset, I would like to thank the organizers for giving WHO an opportunity to be here, to be a part of this great event. Personally, as for me, it is a real, no, it's one of the lifetime moments of my life wherein, being an, as Sir said, being an alumni, presenting here in Bhargav Auditorium, and also being, chair, I mean, being there with my teacher, Dr. Professor Arun Aggarwal, and also my current supervisor, Dr. Yutaro, who is also my mentor. So, and in front of the August gathering, I could see very eminent people, many eminent psychiatrists in this group. So, just a humble presentation from my end. So, essentially, as we have been speaking, and the topic of this session is how mental health is an integral part of sustainable development. So, next slide, please. I would like to present. Okay, thank you. So the presentation, the outline of the presentation will be mental health and SDGs. Dr. Yutaro definitely has given us a very detailed look of how it is interrelated, and how mental health is, it's not a standalone entity, but it is a part of the entire development process. Secondly, the burden of mental health and substance abuse disorders in India, and that is and how these things can be tackled, and WHO has been supporting this agenda. So we saw that during the COVID times, although earlier mental health was definitely a standalone entity, and much of it was on a disease or illness focused approach, but now, with the COVID around, there has been a lot of awakening that mental health has to be incorporated in all the work we do. So, the approach from WHO right now has become from I to we. That means from illness to wellness. So, mental health no longer is just the disease or the illness perspective. It also has a wellness perspective, and which is needed for all. I would say all. I mean, correct me if I'm wrong. So that's number one. Secondly, I to we. I means I stand alone, doing things by myself. The psychiatrist, psychologist community doing it. From there, we've moved to we. I being a public health person, Sir being a public health person, we have taken it up. And there are so many out there who are willing to take up. So this has been a very important paradigm shift. And I'm really grateful to the organizers here that they have felt the need and they have invited us to be here. So I would again reiterate that sustainable development, essentially mental health has been parked in sustainable development goal 3, but definitely has an impact on the others, like the poverty, as Dr. Yutaro had explicitly spoken to it about it. Also upon when we are talking about education quality, then also gender. These are very few which I thought would be very relevant, but definitely there is a plethora of other connections which we saw in the earlier presentation. So when we are coming on to Sustainable Development Goal 3, we are really fortunate that mental health did get a position in the 3.4, but taking it beyond, we can also see that there is a mention in 3.5. Also taking it beyond, we have now seen, the infectious diseases group, wherein, diseases like HIV, AIDS, tuberculosis, neglected tropical diseases like leprosy, where there is a strong element of stigma, discrimination, leading to a lot of mental health issues. Also, many of these drugs used for treatment do have some neuropsychiatry side effects. So there is now a very important shift by these communicable disease control programs to have an inbuilt mental health element in it. Definitely, we have seen now, even at the government level, at the government of India, we've seen there is an approach to have a mental health component in the leprosy elimination program. There is also movement in the HIV/TB program in NACO to have some mental health component. Mental health well-being in per se is what is being emphasized. So that is there, and of course we have the universal health coverage, which talks about quality care and availability of safe, effective, essential medicines for all. So definitely mental health is the need of the hour. And as we all say, no health without mental health. So these things are reiterating. Coming to India, definitely India is now there has been a lot of, and with COVID around, has been a lot of emphasis on mental health. We do have this mental health atlas, which showed a high burden of DALIs for mental health. We also have the suicide rates, which are, the latest one being the 2021 NCRB data, which is pretty high. And also from the National Mental Health Survey, although this is in 15-16, and the current one is going on, but here also things are very alarming. Like it's saying that 10%, 10.6% of people above the age of 18 are having some mental health morbidity. That means, like, if we have 10 people, then one of them is not is having some mental health issue, which is concerning. And definitely this is underreporting because of stigma, because of social outcastism. This mental health issues are very seldom spoken of. People are not free to share their express their concerns. So yes, so how to take things forward? We do have the treatment gap. I mean, if we have seen this, the National Mental Health Survey, it does show a very strong treatment gap. And I mean, we really have to think a solution how to take the mental health care and mental health facilities to the doorsteps of the people. There has been some initiatives by our government, but much more has to be done. So then addiction, definitely addiction, you've seen this is from the Government of India publication in 2019. So we've seen how addiction is also playing a very key role in expanding the mental health disorder cohort in our country, not just the adults, but we also see children who are being affected by these conditions. So, but then not everything is dark. We always have some opportunities and we need to explore more. In terms of, I mean, as far as India is concerned, our country is one of the very, I would say, we had been pretty progressive in thinking and to, identify the need to have a national mental health program that goes back in 1982, wherein the government felt that there is a dire need to have a national level program so that, we are able to reach out to the people to give them the minimal healthcare in the mental health area. And definitely there were two components were further identified. One is the manpower development scheme. Actually, in 1992, the number of 1982, the number of psychiatrists were very few in the country, and other psychiatry-related health professionals were very few in number. The government has supported, and currently this manpower development scheme has really yielded a large number of mental health workforce. But then these were very confined to the centers of excellence, and we needed to move to the community, the district level, which are really I mean, the uptake of services were very little there. So the district mental health program, as we all know, the genesis happened from in demands, and how it was pilot was done in the Bellary district, and it was found to be very effective, and then it was taken up by Government of India, rolled out. And today we see that 714 districts in the country has the district mental health program. So district mental health program essentially has a mental health care cell at the district hospital, which has a psychiatrist, psychologist, as the psychiatric social worker, psychiatric nurse, a monitoring and evaluation officer, and a data operator. But again, the high rate of attrition of the psychiatrists from the district led to the government to think how we can have a pool of psychiatry specialty at the district level. So, as Dr. Yuta had earlier presented, WHO has the mental health gap modules, which talk of training non-specialist cadres who are MBBS, and if they are trained with a package of mental health interventions which are standardized as per the country guidelines, then they can do the early screening and they can initiate the treatment, and very few cases which need further referral can be referred to the tertiary care centers, which are usually in the mega cities and the metropolitans. So taking that forward, the government has developed a lot of modules to train the psychologists. Even for the psychologists, it was felt that there is lack of clinical psychologists at the district level. So psychologists from the general stream were inducted, and they were given a training by which they were able to handle patients. And definitely those which need referral, those which need very focused care were referred to the tertiary care centers like CGI. We are very fortunate in India that we have a standalone mental health policy. Very few countries in the world has given so much emphasis to mental health, and India is one of them. And it is very important for us to find opportunities within the overarching guidelines of this policy, and to take forward initiatives. So this is one of the very important policy guidelines which gives us a lot of footage into the mental health care arena. The Mental Health Care Act, this, as we are talking about, mental health care and human rights, this also has got very, very progressive clause like the decriminalization of suicides, which is very important. And I mean, there are others also, but from a public health perspective, this decriminalization of suicides is a landmark decision which came and has really, has revolutionized the approach of the society, of the healthcare personnel towards people who are unfortunate to have taken such serious steps. So, and coincidentally, this act came into being on 7th of April 2017. As Dr. Yuta had earlier said, that it was the World Health Day dedicated to depression. So it was again a very, very important landmark for the government of India to take some concrete steps further. And as I said, there had been a lot of training packages, drawing from the guidance from mental MHGAP from WHO to create packages for cadres who would be non-specialists, yet would be able to deliver quality care at the district level. Then Ayushman Bharat, which is again a very, very important flagship program of Government of India, launched in 2018. It has the health and wellness center at the community level, and now that we have over 150,000 health and wellness centers in the country, there is a dedicated package called the mental health, neurological and substance use package. Here we do understand that with the lack of mental health professionals like psychiatrists at the health and wellness center level, there may not be treatment disbursement at per se, but the community will be there. There can be programs to increase the community awareness, to reduce stigma and discrimination, and also identify, or at least if there are suspicion of cases which needs further care, then there can be early identification and early referral, so that a lot of cases which are which do get which remains unidentified, and also lack to follow up, because many of the patients, they may be taking the initial first round of treatment and then they don't adhere to it. So such things it will be very helpful for the community workers to go to the patients and keep them motivated so that they continue the treatment. Further, there are initiatives like Telemanas, as we all know, and NIMHANS had been the pioneering and apex center. It is now being implemented, and IPGI Chandigarh also has a center here, wherein it has a system wherein you can call. There is a dedicated number. Initially there are counselors who are trained in counseling, and they give the initial services. But if there is a need, then the calls are escalated to the psychiatrist or psychologist, which is who are also a part of the Telemanas team. And if further personal care is required, then the district mental health program are intimated, and then the district mental health program takes the program further. So Telemanas is mental health assistance and services network across states. So this is something very important, because the best thing is that with the advancement of digital technology in our country, this is a very an opportunity which can be encashed on, and also the privacy and confidentiality of the caller information is secure. Also, we all know that eSanjeevani, we do have the eSanjeevani headquarters in Mohali only. eSanjeevani is a portal wherein one can do teleconsultation, and at the end of it, prescription is generated. And this came very handy during the COVID times when patients could not come in person to the health facilities. And yes, there was a psychosocial helpline from NIMHANS during the COVID times, and this became the precursor for the Telemanas today. And of course, this National Suicide Prevention Strategy, this is also one of the very progressive steps by Government of India to take things forward, and to how to promote mental health promotion, and reduce the incidence of suicides in India. How WHO has been supporting, well, at the country level, capacity building, training of, creating modules for different cadres. We do have, engaged as big institutions like NIMHANS, like PGI, they have all been contributed. And for different cadres, we have, even for the Health and Wellness Center cadre, we do have. Then the National Mental Health Survey, which was there in 2015-16, and the current one being underway. WHO has been giving technical inputs for that. There was a short assessment also in 2019 to see how the quality of district mental health program is there. And also the fourth one is a very important pillar. COVID times, earlier globally, whenever there would be a disaster, mental health was not a very integral part of it. But COVID was a paradigm shift in how mental health is perceived globally also. The response, COVID response, did have a very prominent pillar on mental well-being, and from the Government of India level, this was taken forward, and WHO was the technical support for that. And WHO has been advocating to expand the mental health support. The main important, as Dr. Yuta had said, there was a global campaign in 2017 to enhance the visibility for mental health. And in India, we did have a very important event in our capital in Delhi. Here we can see the then president, minister, and the deputy minister lighting the lamp, and behind is our then WR, Dr. Henk Beckedem. Also during the COVID time in 2020, when COVID struck, then there was the World Mental Health Day was dedicated to increasing investments in mental health. Investments not just mean, in terms of money, but at least the interest that people are showing in mental health is also a very important thing to be considered as an investment. And from there, we've seen how, there has been this we feeling and not the I feeling, which I was describing in the beginning of my presentation. And also very recently this weekend, when this was signed by our globally, this declaration came, we do see a very important emphasis on mental health. This is the mental health and drug programs. So we've seen how the government is now committed to address these, and my appeal to everyone that we should now join hands and think of how we at our own place can do something innovative to contribute to these goals. And key message, definitely mental health is very, very important for everyone and everywhere, wherever we are. Be it we are doctors ourselves, we are practitioners, we are common people, we are into a different profession, whether we are in a city, village, whether in India, anywhere. It is very, very important, and it's right. It's our right, and we all have a lot of right-based literature from WHO giving this direction. Our Mental Health Care Act is also one important step in this direction. And in this year, the World Mental Health Day, 10th of October, the theme is also, mental health is an universal right. So, keeping this in mind, let us all get together, and we should involve all the sectors, not just the medical fraternity. And it is very important to connect, and then only we can function together, we can have good ideas, and then we'll be able to cope up with all the challenges we face in implementing these initiatives, and that is how we can thrive. So, as in India, we all say Sarve Santu Sukhina, Sarve Santu Niramaya. My wish to you all that may you all be happy and healthy, and may we all collectively contribute to take forward the mental health agenda. Thank you.
Thank you very much, Atreyi, for giving us an overview of the India situation and the WHO's work in this country. Next, I would like to invite and introduce Professor Arun Aggarwal. He is the head of Department of Community Medicine and School of Public Health here in the PGIMAR. I think we are running out of time and we don't have enough time to introduce your great achievements. Yeah, but the floor is yours.
Legendary people can see sitting here. So, सबसे पहले आपको प्रणाम. And with this, what I want to say is that we heard. I will make up for the time. My presentation is very short and brief. I just want to touch upon the last mile delivery challenges, just to stimulate your thinking process that how to convert policy into action. Okay, so, and without any offense to WHO, I will just say a joke to you. This is implementation joke. Some of you might have heard about it. This is the story of a centipede. Once upon a time, a centipede with 100 legs got arthritis. How painful it is. So, centipede consulted his spouse, and generally spouses are very intelligent. So, the spouse advised that why don't you go and consult that old wise owl sitting on the banyan tree. Okay, so the centipede went to that owl. Sir, I have this problem. I have 100 legs. I have arthritis. Please suggest me what to do. Owl said, okay, I will give you advice, but don't ask the second question. Okay, sir. Owl said, get yourself converted into two-legged animal. He was very happy. A solution found. Went to the spouse, told that this has been advised. Now the spouse told, you should have asked the owl how to get yourself converted. Oh, I forgot to ask. Again went to the owl. Sir, you didn't tell me how to get yourself converted. You know what he said? This is implementation problem. My role is to give the policy direction. Now, how to get yourself converted is the implementation problem. And that happens. We are very good in drafting policies. Policies are very good. Policies are not like that. This was just to make my point. Policies are not like this that get yourself converted. Still, the policy directions lack the direction and experience how to convert that into last mile delivery, implementation. And this is what I want to touch upon. And I want to say that this Bellary model had come quite late. We had I had joined the department in 92, but we were told that our department of psychiatry was the forerunner to run a community-based mental health care program many years ago. So this department of psychiatry had done excellent work in making that model of community-based delivery, but that could not be sustained over a period of time. But the point is, the objective of my talk here would be, this is a group of young researchers and elite experts. Researchers, what they can do in this field and what this group as a whole, association of psychiatrists, they can do. Last night, I just did a quick bibliometric search of about 10,000 articles published in last more than 10 years. And do I have a pointer or? Okay, here only. So you look at this, the keywords were mental health and primary care. Most of the work, you say, done in US, UK, and all the big words, it means more work has been done. The big is the balloon. So community mental health services, mental disorders, humans, adolescents, depression. So the work has been done. If you look at some of the vulnerable groups like military person and similarly migrants, rural population, different age groups, and if you look at this domestic violence, telemedicine is the latest thing. So much of work has been done in last few years, but still in terms of the cumulative knowledge available, this is not much. And this is one of the way forward, that if we are, like both of our learned speakers have told, okay, so that we are short of resources. Even this district mental health program, when it was launched, then because of lack of psychiatrists, it almost dropped down. If I say that, not total failure, but it was not a success. So we are short of psychiatrists, and there is lot of work available for us. You cannot produce psychiatrists in single year or 2 years. It will take lot of time. So can we allow the mental health problems to remain as such, or we find solutions to it? It was told that very less budget allocation is there. You keep on fighting for more budget, but if you don't have budget, then will this you leave this problem as such, or you have to come up with some innovative solutions? Whatever budget you have, whatever resources you have, how can you efficiently and effectively utilize that, at least to cover those things which can be covered? Everything cannot be covered. So I will present here some of the key points, like Dr. Ganguli mentioned about national health policy. It's a very big document. I have taken only few words to make you realize the gap in policy and implementation. Now it is mentioned equity. Equity means it is not equal. It is means that social justice should be given. Those who have more problems should get more. Those who have less problems should get less. Now this equity in terms of social, cultural, remote areas, rural areas, equitable share of budget in terms of problems, non-discrimination and equal opportunities. Now policy recommends this. Now how to do it? Take this last word, equal opportunities. It means that all those who have some psychiatric problem, they should get equal opportunity in education, in job, in this and that. There should not be any discrimination against them. So now how to do it actually? You know that when recruitments happen, there is some reservation for specially abled, people, but then there is distinction that if you don't have vision, if you don't have hearing, if you are handicapped in terms of limbs, some jobs you can do, some jobs you cannot do. So when advertisement happen, recruitment happen, at that point of time, administration knows that if you in these departments you can employ a specially able person. In these departments you cannot employ. For example, if there is hearing problem, deafness, you will not like that person to be telephone operator like that. If you have loss of lower limbs, you will not like that person to be security guard. But do we have such type of distinction? The different types of psychiatric disorders, which type of employment can be easily given to which type of person so that it suits. Otherwise, you expose by giving it equal opportunity, you employ a person to that position where there is a lot of stress. So you have, as experts, you have to come out with guidelines that people with these type of grades of illness, these types of illnesses, they can perform these types of jobs easily, so that then it can be fed to the implementers that this is the policy, this is the guideline. Now you can reserve these type of jobs for these type of people. Otherwise, this will remain on policy itself. Now, vulnerable and excluded members give justice. This looks okay, and whenever your mental health programs will roll out, you can specially identify who are vulnerable. Like in my first slide, I mean those who are in the jail or army people or such groups which are together and they don't have enough facilities, and now so many displaced people due to war, conflict, violence, community violence. You see that people are displaced and all those become vulnerable. But the last part is this. Okay, only 4 seconds left. Okay, so how to integrate it into the primary care approach? So we, and these are the challenges. So our experience also started with this WHO day, and we also celebrated WHO day and this campaign of talking to each other. It was started, and from here actually we built a small community-based mental health program in our health post, because very small our resident doctors are going. So in this community, when Dr. Ganguli was showing that this day was celebrated and lamp lighting was done by the elite national members, I was thinking that the same day we were lighting the minds of the community here. And in this small gathering, when we told them, some of them came out with their stories. They opened up, they started talking. And after this, we, with the help of psychiatry department senior residents, and we trained our staff who did a small community-based survey in that area, identified people. And this is not a rocket science, but this is the standard model. You raise community awareness, you set up a screening program, and then you should have a referral clinic where these people can be dealt with. We also did the same, and ultimately we could diagnose some cases and treat them. But this was not the end. This was the beginning. When all these patients were going to a clinic to get the treatment, that clinic was around 2 kilometers away from this village. But even people were not ready, willing to move out to that village. How to travel? Because these people were not independent enough, and family will not support them. So they will not support them, they will not go with them, and there is huge rush in the clinic. They feel that they are alone, no one to take care of them. Such type of problems come. So lack of transport, high waiting time, neglect of elderly and support, etc. Then we provided them with all that. We made the program that our vehicle will go every week to the psychiatrist, take some patients and assist them so that they are seen on priority, they get the medicines and they come back. When this last mile problem was solved, then again the uptake of mental health care service improved. So the message is that if you want to convert policy into action, you have to think about the last mile delivery challenge. And like all the service agencies, whether this is food or this is transport, there is Uber or Ola, or you order on online any food, everyone has solved the last mile delivery. So if we don't solve the last mile delivery, these policy guidelines will remain in the books or partially implemented. And last was the, I will skip this, both the speakers have talked about it, that talk, treat and transform, this we have seen, this technology and training is one very important part. You have to train the community physicians, you have to train the community health officers, ANMs, everyone who is working in the field, and they should have a designated role. If they cannot screen the patients, if they cannot treat the patients, but train them how to listen effectively. You see, the Lord Ganesha, what is the significance of Lord Ganesha? Many significance we teach in management, but one of the significance is large ears. You have to be very good listener, and you know who knows better than you that if you are listening effectively, 80% of the problems are gone. People become stress free if someone is listening to them. We in the health system do not listen to the people, their voices, and we do not give the enabling environment. In our busy clinics in the periphery, in each clinic, there are 20-30 people standing when doctor is examining the patient. Doctor will keep on saying, I am having this, patient will keep on saying, I am having this problem or that problem, but problem was something else because we didn't provide privacy to them. So if you give them audio visual privacy and listen to them, the problem would be solved. I end my talk with this.